Can anybody tell me the uses of the digoxin? What are the uses of the digoxin mainly? Uses of the
Heart
digoxin.
failure.
Sorry?
Used in heart failure.
Exactly. For what purpose?
To increase contractility.
Exactly. So another name of the contractility is, what is another name of the contractility?
Inotrophy.
Exactly. So any other use of the digoxin?
Yes, it's used in tachycardia because
Okay, it's used in atrial
it's used in
fibrillation.
tachycardia. Atrial fibrillation.
Atrial fibrillation, right? So
Yes.
the mechanism of the digoxin is a super high yield, right? So what does digoxin do? Digoxin block the primary active
Sodium
transport.
potassium ATPase.
Okay, so the digoxin block the primary active transport. Like, let's suppose this is a primary active transport. What primary active transport do with sodium and potassium? So the sodium moves out, right? And potassium move in normally
Yes.
through the use of ATP. So this pump is primary active transport is necessary for the secondary active transport. So the secondary active transport that takes place is sodium calcium exchanger, right? So in this sodium calcium exchanger, sodium move inside. Hello?
Yes. Hello. We can hear you.
Okay, so the sodium move inside and calcium move outside. This is normally happen. So the digoxin block this transport. So the digoxin, this is the target of action. Sometimes USMLE give you this kind of the flow chart and you label the where does this they give you the side effect of the drug. So sometimes they give you the side effect of the drug. What are the side effects of the digoxin? The most highly
What you have yellow vision?
yes, the most important one they give in the scenario, vision problem. What kind of the vision problem?
Yellow.
Blurry yellow vision, right?
Yes.
Right.
Yes.
Arrhythmias. So sometimes they give you the these kind of things, blurry yellow vision, arrhythmia, and sometimes they give also the hyperkalemia. So this digoxin also lead the hyperkalemia. Why? Because this potassium that is present in the extracellular space does not move inside. So this potassium present outside and it will lead to the hyperkalemia. Sometimes they give this kind of the thing and they try to ask about the mechanism of action in this type of the picture thing are you simply in the text format, right?
Yes.
So so in heart failure, digoxin lead to the increased contractility, but it also used in atrial fibrillation. Atrial fibrillation. So what is the mechanism? How can it relieve the symptom of the atrial fibrillation? Digoxin. Can anybody tell? What
Stimulate
is
the vagus nerve.
exactly the it stimulate vagus nerve as well. So vagus nerve is parasympathetic or sympathetic?
I think it's what, para?
It's a
Parasympathetic.
parasympathetic. Whenever parasympathetic activation take place, so what happens? M2 receptors. M2 receptors that are present on the SA and AV node. activate, and these receptors lead to the decrease in conduction at AV node and decrease in heart rate due to the depression of this SA node. Right? Does it make some sense to you?
Please, can you repeat that? Sorry.
What thing I should repeat? Can you please highlight me?
You said the M2 receptors are present on the SA node and AV node. I
Yes.
didn't hear what you said next.
Okay, there are many types of receptor, M1, M2, alpha 1. We will discuss these receptors in detail
Okay.
in next. But you remember the key thing is M2 receptor present in the SA node, right?
Yes, yes.
Or they are activated by parasympathetic activation. So parasympathetic activation mainly, right? So you know that
Yes,
parasympathetic activation lead to the decreased heart rate. Through which receptor?
yes.
M2 receptor.
Okay.
Okay?
Okay.
Rock, does it make some
Yes.
sense to you?
Yes.
Okay. So these are the some causes that lead to the decreased contractility. Beta 1 blocker, because the beta 1 blocker, heart failure with systolic dysfunction, acidosis, hypoxia, and non-dihydropyridine calcium channel blocker. Can anybody name the non-dihydropyridine calcium channel blocker?
Yes,
Diltiazem
that'll
and
be
verapamil.
verapamil.
Verapamil. They mainly
Yes.
act on heart.
The
And what are a
heart, ventricles.
dihydropyridine calcium channel blocker?
And that'll be like your nifedipine
Exactly. And they mainly work on the vessel,
and the vessels. Yeah.
right?
Yes.
Okay. So what is a preload? So the preload is basically, it's approximated by the ventricle and diastolic volume. So it is approximated by ventricle and diastolic volume, and it depend upon the venous tone and circulating blood volume. Okay, there are in coming slide there's so many graphs and curves that are super high yield. They're highly tested in NVMe and U world. So try to understand this preload concept. Okay, so basically the preload is determined by ventricle and diastolic volume, and this ventricle and diastolic volume determined by the venous tone and circulating blood volume. Okay, so which receptor present on the vein? Can anybody tell me which receptor are present on the vein?
We have A1, alpha 1.
Alpha 1 receptor, right?
Yes.
So alpha 1 receptor are present on the vein. So what happened when you activate the sympathetic system? What happened to the preload in the sympathetic activation?
Preload is supposed to increase. So
Okay,
that'll
so
be from the
So
constriction.
in sympathetic activation, venoconstriction take place through the alpha 1 receptor. Try to remember the name receptor, like M2 receptor where present, alpha 1 receptor present on the veins. Like
Right.
veins are also called storage vessels. They have high capacitance. Okay. So the sympathetic activation lead to the increased preload. And what happened when you give the IV fluid? IV fluid. What happened to the preload in IV fluid?
It increases.
Yes,
Okay.
because fluid comes into the veins and there is increased venous return, right?
Yeah.
So the preload will increase. And what happened when you give the nitrate? So nitrates, what happened?
Venodilatation.
There's been dilatation, so preload will decrease.
Okay, so preload will decrease. Okay. So this is again, I discussed this concept in the previous lecture. So usually we give nitrates in MI. Can you tell me the which type of the MI this nitrate is avoided? Nitroglycerin. Hello?
Right-sided, right-sided heart failure, because we said yesterday it's contraindicated.
Yes, it's a contraindicated, right ventricle infarct. Okay.
Okay.
So the next is the afterload. So what is afterload? So the afterload is basically determine the mean arterial pressure. So if there is increased mean arterial pressure, it means that afterload is increased. If there is decreased mean arterial pressure, it means afterload is decreased. So
can you repeat that, please?
okay. So the afterload is mainly determined by mean arterial pressure. If the blood pressure or mean arterial pressure is increased, it means if mean arterial pressure is increased, it means afterload is increased, right?
Yes.
If it is decreased, mean arterial pressure, it means afterload is decreased. It's a simple thing. Okay. Now you have to remember these drugs. So hydralazine decrease afterload because it is a arterial vasodilator, and nitroglycerin is mainly, they have effect on veins as well, but they mainly, like if you're talking about the nitroglycerin, so the nitroglycerin mainly effect on the veins, but they have also effect on the arterial as well, right? So nitroglycerin decrease the preload mainly, while the hydralazine causing arterial vasodilation lead to the decrease afterload. Okay. So the ACE inhibitors and ARB, angiotensin receptor blocker, decrease both preload and afterload. Okay, one more thing. Chronic hypertension lead to the left ventricle hypertrophy. Okay, so the two type of the ventricle hypertrophy. Can anybody tell me the two type of the ventricle hypertrophy?
Eccentric or concentric?
Exactly. This is a highly repeated concept. Eccentric and concentric. So the two type of the hypertrophy, eccentric and concentric. Right?
Yes.
So this eccentric hypertrophy takes place in which condition?
Dilated.
Volume overload.
Exactly, volume overload.
Yes.
So it takes place in volume overload. While concentric hypertrophy takes place in pressure overload.
Overload.
Yes.
Okay. So can anybody tell me the condition of the volume overload?
Yeah, so you in dilated cardiomyopathy, I believe you can
Yes.
see that. You can see it also.
Dilated cardiomyopathy. Okay. Anything else?
Congestive heart failure.
Okay. So volume overload, right? Congestive heart failure. Anything else? Any valvular pathology? Can you name it the valvular pathology?
Mitral regurg, aortic regurg.
No,
Yes.
aortic regurg. Yeah.
Mitral regurgitation and aortic regurgitation mainly, right?
Yeah. Yeah.
So what is the mechanism of the eccentric hypertrophy? This is again high yield.
Yeah, this one the cells are arranged in series.
Sarcomere added in
Sarcomere. The
added
sarcomeres
in
here
added in series.
In series, yeah.
And what is the mechanism of the concentric hypertrophy?
So you have
Sarcomere added in
sarcomere
parallel fashion,
parallel.
right? And what is the
Yes.
condition of the pressure overload causes of the concentric hypertrophy?
chronic
Pressure
hypertension.
Sorry?
Left ventricular hypertrophy.
Chronic hypertension, right?
Yes.
Aortic stenosis.
Aortic stenosis, Frederick ataxia, aortic stenosis, right?
Yes.
These are the two types of the hypertrophy, eccentric and concentric. Their mechanism, their causes, again the highly repeated concept. So I thought that I should repeat these things for you. Okay, Rock, did it make some sense to you?
Yes.
Any question regarding this type of the hypertrophy?
No, I think it's clear.
Okay. Afterload. So we did the afterload. Okay. So cardiac oxygen demand. So cardiac oxygen demand is increased by which factors? These are CARD, the mnemonic of CARD. Wait a minute. CARD. CARD. C for contractility, A for afterload, and R for rate, and D for increased diameter of the ventricle, increased wall tension. And the coronary sinus contain most deoxygenated blood in the body, right? Coronary sinus drain into which chamber of the heart?
The right atrium.
The right atrium.
Right atrium. So anything that dilates the right atrium will lead to the dilatation of the coronary sinus. Okay, so the wall tension follow the Laplace law. The wall tension is equal to the pressure multiplied by radius. So the wall stress is equal to the pressure divided into pressure multiplied into the radius and wall thickness, right? So the wall stress is directly proportional to the pressure and it inversely proportional to the thickness of the wall, right? Wall stress is directly proportional to the pressure and it is inversely proportional to the thickness, right?
Yeah.
Okay. Stroke volume. So we already discussed the stroke volume. So what is the stroke volume? Oh, okay. The stroke volume is basically the volume that is ejected by ventricle. That is ejected by the ventricle. The stroke volume is end diastolic volume divided by end stroke volume. The stroke volume, they ask about the stroke volume in the graph. In the next few slides, we have a lot of graphs. So we will discuss the stroke volume in that graph. So they ask the stroke volume in mainly the graph and curve, cardiac curves and graph, right?
Yeah.
Okay, so the ejection fraction. So the ejection fraction is basically stroke volume divided by end diastolic volume. So this is a stroke volume that is divided by the end diastolic volume. So end diastolic volume mainly, end diastolic volume determine which thing? End diastolic volume determine which thing?
Preload.
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 Preload. Right?
Yes.
And this stroke volume is, we already know that, is the ejection of the blood that take place from the ventricle. So the ejection fraction is basically the index of the ventricle contractility. If ejection fraction is decreased, it means patient has a systolic heart failure. Systolic heart failure. If ejection fraction is normal,
Diastolic heart failure.
it may be the diastolic heart failure, it may be the normal. So the normal range of ejection fraction is 50 to 70%.
55.
Right? So if the ejection fraction is decreased, it means systolic heart failure. If the ejection fraction is normal, it means maybe the diastolic or maybe the normal. Right?
Yeah.
Okay. So the cardiac output. So the cardiac output is basically stroke volume divided into the heart rate. So this is another principle, Fick principle. The Fick principle state that rate of O2 consumption divided by the arterial O2 content minus venous O2 content. So in the early stages of the exercise, this cardiac output is maintained by heart rate and stroke volume. But in the latter stages of the exercise, this cardiac output maintained by increased heart rate only, and stroke volume become plateau. In the early stages of the exercise, cardiac output maintained by both of stroke volume and heart rate. While in case of the latter stages of the exercise, this cardiac output is maintained by heart rate only. Right?
Yes.
Okay. So this is a simply U-word and U-word stuff. So they ask about the diastole is shorter in increased heart rate. So if diastole is shortened, so the cardiac diastole means filling of the ventricle. So they ask you question about if the heart rate is increased, what happens to the filling of the ventricle? Decrease, remain same, and it will decrease. Increase, decrease, remain same. So if heart rate is increased, what happened to the ventricle filling? Hello?
Can you repeat the question, please?
I say that if the heart rate is increased, what happened to the ventricle filling? It will decrease,
It will
increase, remain
decrease.
same.
It's going to decrease.
Okay. So heart rate, increase heart rate lead to decrease ventricle filling. Decrease ventricular filling. Right? Diastole,
Yes.
you simply mean the diastole mean simply. Diastole mean ventricle filling. Systole mean contraction of the ventricle. Right?
Yes.
Okay. So if the ventricle filling is decreased, so what happened to the stroke volume and the cardiac output?
Yes. They will both decrease because due to insufficiency.
Okay, there is a concept, Frank-Starling mechanism. Below there is a curve where I discuss detail in the Frank-Starling law, Frank-Starling principle, Frank-Starling principle. So, if there is a decreased preload, it will lead to the decreased stroke volume and cardiac output, right?
Yes.
Okay, so the pulse pressure. So pulse pressure is basically the difference between systolic blood pressure and diastolic blood pressure, right? So the pulse
Yes.
pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. Arterial compliance. So you have to remember these conditions, cram these conditions, right? So the pulse pressure is increasing, aortic regurgitation, aortic stiffening, obstructive sleep apnea, high output status like anemia, hyperthyroidism, and exercise is transient. What happened to the decrease in pulse pressure causes are? Rock, decreased pulse pressure causes are?
Aortic
Rock.
Yes,
stenosis.
yeah. If you're in shock due to low pressure, you can have decrease in pulse pressure as well, and that's what ties in with cardiogenic shock and tamponade.
Okay. So the pulse pressure is decreasing, aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. Okay. Asma, can you repeat the causes of the increased pulse pressure?
Oh, yes, it increase in aortic regurgitation, aortic stiffening, and obstructive sleep apnea, high output state like anemia and hyperthyroidism, and exercise.
Okay. Rock, can you repeat the causes of the decreased pulse pressure?
Yes, so decreased pulse pressure would be due to uh, cardiogenic shock, cardiac tamponade, as well as heart failure and aortic stenosis.
Okay. Okay. So this is the mean arterial pressure. So the mean arterial pressure. So the mean arterial pressure is basically cardiac output multiplied by TPR, total peripheral resistance. We will discuss these total peripheral resistance in detail in the next slide. Okay. So the cardiac output and total peripheral resistance is equal to the mean arterial pressure. If there is a decreased mean arterial pressure, what happened to the afterload? It is
Decreased.
decrease
Decreased.
afterload, right?
Yes.
Okay. So if there is increased TPR, what happened to the afterload?
It will increase.
It will
Like
increase
increased TPR, increased mean arterial pressure, and increased afterload.
afterload.
Okay. So the U-World NBME is turn around this kind of thing. Increase preload, increase TPR, this kind of the things. So the TPR is mainly determined by total peripheral resistance is mainly determined by which vessel?
Afterload.
Okay, so which vessel determine the
Arteria.
TPR? Sorry,
Arteria.
arteriole. So this TPR is determined by arteriole, right? So if there is a constriction of the arterioles, what happened to the TPR?
Will increase.
Exactly. So they give you the drugs that lead to the increased TPR, and they ask about the afterload, these type of the arrows question. Arrows question. We will discuss these question in detail as well. Okay. So TPR is determined, is dependent on the arteriole constriction. If the arterial constriction takes place, it will lead to the increased TPR, right? Can you tell me the any drug that lead to the increased TPR? One drug.
السمباسومايميتيك الادرينالين نورابinefrine
Exactly, norepinephrine.
vasopressor.
Can you tell me the any drug? Can you tell me the any condition that lead to decrease PPR?
الهيدرولازين which mainly act on the arteriolar dilatation.
I'm talking about the condition.
And
can you tell me the condition?
shock.
Exercise. Exercise lead to the vasodilation. Vasodilation. Right?
That's right.
So these kind of the things you have to remember. Right? Okay, we have less than 1 minute. We stop this session and we will continue from the next session. So these Starling curves are again the high yield curves. So what is Frank-Starling law say that if you increase the preload within physiological limit, if you increase the preload, you will increase the stroke volume or cardiac output, right? So this is basically increase. This is on x-axis. We have a preload, and y-axis we have stroke volume or cardiac output, right?
Yes.
Okay. So this below line show the normal in exercise, right? And this is normal relationship between the preload and the stroke volume at rest, right?
Yes.
So what happened in the heart failure? This relationship is impaired, right? This
Correct.
relationship is impaired. So this is the heart failure relationship. If you give this patient, if you give this patient a inotropic, like, so it will increase their cardiac output, stroke volume, contractility. Like here is this preload, the contractility or cardiac output at stroke volume is this. If you give this patient inotrope like dibutamine, milorin or digoxin, so what happened? The preload remains same, but the cardiac output or stroke volume is increased, right?
Yes.
Did you understand this thing?
Yes, I think we have it.
Okay. So the force of contraction is proportional to the end diastolic length of the cardiac muscle fiber. It means if you is a simple is again the paraphrase the thing. Increase preload, increase cardiac output, increase stroke volume within physiological limits. So they defined the preload in another mean, and diastolic length of the cardiac muscle fiber is preload. So the contraction is dependent on the preload, right? So
Yes.
another definition of the preload is end diastolic length of the cardiac muscle fiber. If you have increased preload, it means increased force of contraction, right?
Yes.
And these sometimes they give you the myocardium, MI, heart failure patient, and you have to identify the curve, right? You have
Yes.
to identify the curve. So MI, beta blockers, non-dihydropyridine calcium channel, they decrease the contractility, right? So curve is this. Their curve is in this red line. Decrease contractility or heart failure. This curve is this one. If you increase the contractility, then the curve becomes this orange color. Does anyone has a question regarding this Frank-Starling curve? A Starling curve? Asma?
No, it's clear.
Okay, it's clear. Rock?
Yes, it's clear.
So this curve is, this graph is high yield. Okay, this is again this revision to the resistance. So the resistance is basically the obstruction to the opposition. Basically, it is a resistance, is basically the resistance or opposition to the flow of the blood, right? So resistance can be arranged in two ways. This resistance can arrange in two ways. One is parallel and other is
Series.
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 So what happens in parallel resistance? Parallel arrangement of the resistance. The total resistance of the vessel is decrease. In parallel, it decrease. Total resistance decrease. Okay. But what about the blood flow? Let's suppose here we have 100, suppose 100 value of the blood flow. So the blood flow will distribute. Here we get
Yes.
20, here we get 60, here we get 40. So each organ receives the fraction of the blood flow. So the blood flow in the parallel resistance does not remain same, right?
Correct.
But the pressure, but pressure remains same. Can you repeat the three things about the parallel resistance? Asma, Rock, can you repeat? Three
Yes.
things
So
about
in parallel, the blood is distributed, so it's not equal. The organs receive a fraction of the blood, and also that pressure is constant in the parallel.
And what about the total resistance in a parallel arrangement?
Is decreased.
Okay. So the opposite in the series resistance, right? So
Yes.
opposite things takes place in the series arrangement, right? So the total resistance will increase in series, right? So
Yes.
the formula of the resistance, this is the key thing. This one. So the resistance formula is equal to 8 viscosity into length divided by pi r, right?
Yes.
Okay. If you increase the viscosity, what happened to the resistance? If you increase the viscosity,
I think resistance will increase.
right? In which condition viscosity is increased?
Polycythemia rubra vera.
Polycythemia.
Polycythemia and
Rubra vera.
okay, right, and hyperproteinemic state. Polycythemia, hyperproteinemic state. And which condition viscosity is decreased?
Anemia.
Anemia, right. So the viscosity is mainly dependent on hematocrit. What is a hematocrit? It is a fraction or percentage of the RBC in the whole blood. The fraction of the RBC or percentage of the RBC in the whole blood is hematocrit. If hematocrit is increase, any condition that lead to the increase RBC, it will lead to the increase viscosity, right? So if there is increased viscosity, it will offer higher resistance, right? Increased
Yes.
resistance. And we already discussed arteriole account most of the total peripheral resistance, right? So one more thing regarding the capillaries. Capillaries has highest total cross-sectional area and lowest flow velocity. What is the significance of this? Capillaries have highest total cross-sectional area and lowest flow velocity. Why the capillaries have highest total cross-sectional area? What is the significance? Rock, Aisha,
Well,
Mudassir, anyone?
Supply of the organ.
Is it
Supply of the
about
organ.
compliance?
Okay, so the mainly significance to diffusion, to exchange of the substances. If you have a greater cross-sectional area, the exchange of substance will take place easier, right? And if you have the lowest velocity, the exchange of substance will more, right? The exchange of material takes place in the capillaries. Am I right?
yes.
Yes.
So that's why the capillaries have the highest total cross-sectional area and lowest flow velocity, right?
Okay. Now, so can you just repeat the entire concept so that there's a clear flow
Okay, so first we
of the
discuss about the
capillaries?
resistance. I am going to summarize the thing because we have shortage of time. So resistance arrangement in two types. Hello, hello.
Yeah, we're here. If somebody was talking, they need to mute their phone.
Okay, can somebody mute? Okay, so Rock, which I am going to summarize the thing. Resistance arrangement in two types, parallel and series, right? In parallel arrangement, the total resistance will decrease. In series arrangement of the resistance, the total resistance will increase, right? And resistance is basically is equal to 8 viscosity divided multiplying to the length and pi r. So the resistance is directly proportional to the viscosity. If you increase the viscosity, the resistance will increase. If you decrease the okay, so sometimes they give you the multiple myeloma, polycythemia in hematology, and they ask about these kind of things. What happened to the resistance? What happened to this kind of? Sometimes they give arrows, right? What happened to the viscosity? What happened to the resistance? 2, 3 arrows. So if this kind of the thing they ask these concepts in NDME and U1, right? Okay, I give you the example. Like they give you the multiple myeloma, the clinical vignette of the multiple myeloma, right? So they give you the some arrows question. Like they ask about what happened to the resistance of that patient, right? What happened to the viscosity of that patient? What happened? These two things, this kind of the thing. And sometimes they give the example of the polycythemia, the condition of the polycythemia, right? You have already they are asked about resistance. What happened to the resistance? Increase, decrease, remain same. And what happened to the viscosity? Increase, decrease, remain same. These kind of the things that the and what happened to the hematocrit, right? So this is the application of this concept in the question. Okay, should we move to the next thing? Rock?
Yes.
Yes.
Rock is my friend, so I remember the name of the rock. So, Rock, should we move to the next?
Yes, yes. I think it's clear now with everybody.
Okay, so this is the curve. So this is the last topic of today's discussion. Okay, so it's a little bit difficult one, but I will try my level best. Okay, so basically this is a combination of the two graphs. One is the cardiac and one is the vascular function. Okay, so this is okay. So annotate. So this one is cardiac function curve, and this is vascular function curve. Okay, on x-axis we have right atrial pressure. On y-axis we have a cardiac output and venous return. Right?
Yeah.
So this one is a normal. This is a normal. Okay. So this is normal. So in exam, they give you the drug like dibutamine, digoxin, or exercise. And what happened to this cardiac and vascular function curve? So dibutamine, what does dibutamine do to the heart? Can anybody tell?
Increase in contractility.
Increase
Increase
contractility.
contractility. So this x-axis, so this is moving towards this side, right? Increase
Yes.
inotropy, increase contractility, increase cardiac output, increase stroke volume, right?
Okay. Yes.
Okay. Sometimes they give you the scenario of the heart failure, narcotic overdose. So the narcotic overdose lead to the sympathetic inhibition. Sympathetic inhibition means decrease norepinephrine. So decrease contractility. Heart failure means decrease contractility. So this one is a normal, and if the patient is suffer from the heart failure, what happened to their contractility? It will increase or decrease.
Decrease.
So it will decrease. So they give you the clinical vignette of the heart failure, and they give you the graph 4 to 5 graphs, and you have to identify the right graph, a right graph, right? A right option regarding these kind of the graph. Rock, does it make some sense to you?
Yes.
We have already short of time. Okay, repeat. So please, in graph A. So this graph A is basically the inotropy. So inotropy, catecholamine, dobutamine, what does do they inotropy? They increase the inotropy. And heart failure decrease the inotropy. Inotropy means contractility, right? I am repeating this concept again because you asked that. Please repeat. So like this green, this one is a normal. Like if you give at this position dobutamine, a drug, so dobutamine lead to the increased contractility. Contractility mean inotropy, right?
Yes.
Sorry, not working. Contractility, increased contractility. So this contractility that present here, it will increase, right?
Yes.
If you this subject, if you give this subject narcotic overdose, narcotic overdose. So this narcotic overdose lead to the sympathetic inhibition, right? Sympathetic inhibition lead to the decreased contractility. So this contractility that is here, so it is decreased. So it moving toward down, right? So inotropy is basically the contractility of the heart. Inotropy and contractility are the same thing. Okay, the next is a venous return. So this graph is a venous return. So venous return is increased by, tell me the condition in which venous return is increased. Tell me in which condition the venous return is increased.
Blood transfusion.
Fluid infusion. Increased
IV
sympathetic.
fluids.
AV shunt. So this is normal. This is a normal vascular function curve. This is a normal cardiac function curve. Okay. So if you give fluid, so what will happen? It will increase the preload, increase volume, increase venous return. If you give that subject increased fluid, so it will lead to the increased volume, increased venous tone, increased venous return, right? So if this subject lost the blood, where he massive loss of the blood, so what will happen to the venous return? It will decrease, right?
Yes.
Okay, you have to understand where the arrow moves, right? If you infuse fluid, increase the sympathetic activity, it will lead to the increased venous return. We will discuss the mechanism how the sympathetic activity increase the preload, because epinephrine cause the venoconstriction through which receptor? Through which receptor, Rock? Can you repeat which receptor?
Alpha 1.
Alpha 1. Alpha 1 receptor.
Alpha 1, yes.
Okay. So same way, if we massive hemorrhage lead to the decreased venous return, decreased venous, because the blood that is a veins are the storage vessels. So blood is lost. So the storage capacity of the vessel is decreased, and the blood in the vein is decreased. So the venous return that coming toward the heart is decreased, right?
Yes.
Spinal anesthesia also lead to the decreased venous return, right?
Yes.
Okay. So the next curve is about total peripheral resistance. Total peripheral resistance. Okay. So the total peripheral resistance is determined by which vessel?
Arterioles.
Arterioles. The total peripheral resistance is determined by arterioles, right?
Yeah.
So if you give the vasopressors, so what happened? If you give the epinephrine, norepinephrine, so it will lead to the
increase total peripheral resistance.
Increased total peripheral resistance through the alpha receptors. And we already discussed about the vasodilation take place. Arteriovasodilation take place in exercise. So in exercise, CPR will decrease. So this is the normal vascular function curve, right? So
okay, yes.
if you give the vasopressor drugs, if you give the vasopressor drug, what happened? TPR is increased. TPR is increased. So the TPR and cardiac output has a opposite relationship, right? If TPR is increased, cardiac output will decrease, right?
Yes.
Same thing if the exercise
Can
lead
you
to the
explain the mechanism of action? How do these vasopressor work? How will they decrease the TPR?
okay. So it's a thing vasopressor receptors, alpha 1 receptors and beta 2 receptors. So mainly they act to the beta 2 receptor. Beta 2 receptor lead to beta 2 receptor lead to the vasodilation. Alpha 1 receptor lead to total peripheral TPR. Like if you alpha 1 receptors are present on arterioles, right? Alpha 1 receptor also present on the vein. So in vasopressor, these alpha 1 receptors, when they are stimulated by these drugs, so it will lead to the constriction of these arterioles, right? So this constriction of these arterioles take place, it will lead to the increased TPR. So the constriction and dilation. If you constrict the arteriole, it will increase the TPR. If you dilate the arteriole, it will decrease the TPR.
TPR. Right.
TPR means total peripheral resistance, and TPR is mainly determined by arterioles, and it is mainly controlled by autonomic nervous system, right? So we will discuss the Vigor's diagram, ECG, and cardiac cycle tomorrow. I will share the link so you can join that tomorrow. Take care. Bye bye.
What time tomorrow? Okay, you